I would like to thank AIOS for this opportunity. So I'll be talking about my personal experience with chronic macular TIDs and the surgical challenges. So these are a few of the cases which I would be presenting. We know it's quite personalized and a steep learning curve. So this is my take on it. So a desired TID outcome would be, we would like to have this when you see a patient from CFCF to 6-9, but it doesn't go always like that. We do get these cases which are chronic tractional retinal detachments. What do you call the literature shows that more than 6 months of duration. These are thin and atrophic retina, extensive, thick, and plaque-like fibrovascular membranes. The issue is the literature is very less, and there are no guidelines, and it all depends on individual experience and skill set. So proper case selection is critical, and to kind of get a optimized surgical outcomes. So I'll show you some cases wherein it's a bilateral case of TRD. It's a 36-year-old gentleman, DM nephropathy. This was a chronic TRD. Except this point, I didn't see anything else really difficult. This was a focal traction, which had kind of caused a contracture there. And left eye already had a TRD, but the vision was ambulatory 636. So since it's an young patient, I thought I'll operate the right eye first. So surgery was good. There was no issues except he had very bad hypertension because of the renal issues, 240, 140, 150. So I had to wind up the surgery. There was a severe bleed that couldn't be controlled. So that kind of went and became the membrane, pre-retinal membrane. And again, there was a tractional retinal detachment. The problem was the eye was lost. The patient was lost for follow-up for a month, and there was severe secondary ocular hypertension. So I couldn't touch the eye once again. But where in the left eye, I could have a good outcome after the vitrectomy. So this is another case of DM nephropathy. Again, bilateral TRD. I operated in 2017. It was a difficult dissection, and I had to do an RR superiorly to settle this retinal detachment. Whereas the hyaloid again here was very tough, so I didn't go in for an RR. So what had happened is after that the vision was good for quite some time. For 2 years the vision was 624. Post S4 there was a thick PCO that had formed. Since there was nothing happening or nothing prior NVA and NVA before, so I went and did a YAC caps, and immediately 5 days later he came in with a neovascular glaucoma. So we even published this. NVG is we know that it's very common in diabetic patients, but post vitrectomy we should keep in mind about the ischemic retina. So this is a case of tractional retinal detachment. So we can there was a nasal prolif that was very taut, and it was a little inseparable. So I tried separating that. There was a hyaloid attachment there. So I had to end up doing an RR since there was a break there. So the RR part really didn't come in the editing issue. So this is how it is. This was pre-op. This is again an young patient at police. So I had to do an RR to this end, and he's doing fine. So maybe a conservative approach in this case and an ensacclage would have helped maybe. When we have a break in a peripheral dissection, then sometimes RR becomes imminent to avoid re-RDs. Then again, chronic extramacular TRDs, this we see day in, day out, as Dr. Sharath was also talking. So when you have such a situation there, when there's just a posterior pole is lifted, the arcade is lifted, and the macula is still on with good vision, we contemplate on what to do, what not to do. So these people end up having subretinal bands. So this is post-surgery. Ultimately, I had to operate, and he settled well. Then again, there's a different dilemma whether to operate, not to operate. Good vision, government official, 618. Strangely, though, there was intraretinal split and there was a traction inferiorly. So finally, he ended up with a CRD. So I had to operate. He's doing okay, but the problem is I had issues with the peripheral dissection because of the schisis, because of the thickly adherent hyaloid there. So he's due for SVR. So hopefully, he should improve further. So this is a case maybe we could have done an early surgery, but when you know that that's a better eye, and sometimes when the patient is not very keen, so we don't know really what to do. So this is another case wherein SR bands very, very close to the macula. So you can see the tautness of the posterior pole. Since it is closer to the macula, we need to be a little more careful. So I've done a retinotomy and removed the SR band there. But what had happened is there were SR bands even superiorly. So again, I had to make another retinotomy, and this time there were diffuse SR bands. So I had to kind of literally take it out with cutter, and then there was an SR band that was running right across temporal to the macula, which I had to again pick it up. This is a typical chronic case of a chronic TID, and by manual dissection sometimes we need to start with the word go, wherein you have to use multiple combinations of scissors and cutter, and you can see the dissection there. So hemostasis again is important, and SR bands sometimes we need to kind of make multiple retinotomies to take it out to kind of flatten the retina. Once it gets mobile, you know that there are chances of the retina settling. So I kind of looked into the literature, what the tractional retinal detachment says. So there was a meta-analysis in 2023. So they had done analysis of 406 studies. So the point which was rotating around was the preoperative BCVA. So all the studies, most of them kind of focused on preoperative BCVA. So when they had a higher preoperative BCVA, the outcomes are better, and early intervention was suggested, and the other focus was to identify patients at high risk. So this was an only article I found on chronic retinal detachments, chronic macular TIDs. So then again, this also focuses on the preoperative vision. Yes. So, and older age and ischemic macula. So anti-VEGF role in better dissection, not vision directly, but macular perfusion status. So to conclude, the many factors, if you look at it, the duration, the existing ambulatory vision, and the OCT biomarkers, they do help. But the best part is, the most important part is the patient understanding and motivations. We do understand that the patient has a poor memory, and they do come back with complaints. So multiple additional opinions can be taken so that the patient is satisfied. Surgery, I feel personally, better shouldn't be hastened up. The patient, you have to give it some time. Patient has to earn the surgery. It's a steep learning curve, and we should understand that anatomical success is not everything. Thank you so much.
Thank you, Santosh, for an excellent presentation.